members from PESC, that is Pediatric Endocrine Society Kenya, and from Congenital Health Africa. So we'll be joined by Dr. Paul Igon, who is a pediatric endocrinologist, a lecturer from the University of Nairobi, and a member of PESC. Like I said, it's Pediatric Endocrine Society of Kenya. And he will talk about congenital adrenal hyperplasia and challenges faced by patients in Kenya. We are also honored to have Dr. Esther Kobel. She's a pediatrician and a child health advocate. She is a co-director of Planned Child Health of Africa, and she's from Uganda. She will talk about access to medicine and diagnosis for children with CAH in Uganda. For our group, Magic Foundation Africa, we are honored to have our guest. Magic Foundation itself is an international organization that supports patients with endocrine conditions. We are also a patient advocate group. We are an international division of Magic Foundation USA and also members of ICOSEP, which stands for International Coalition of Organizations Supporting Endocrine Patients. We support patients by emphasizing on the importance of monitoring children's growth and educating the public about endocrine conditions affecting children for the purpose of early diagnosis and treatment. Today we are honored with dedicated doctors who are so much dedicated in their work to improve the health and the well-being of children here in Kenya, Uganda, and the entire Africa. So Dr. Ligon, you can take over. Hello, Dr. Okay.
Yes. Good evening, everyone. Yes, Riziki, you're saying something.
Oh, sorry. There was issues with communication. It's okay. You're audible. Karibu, Daktari.
Thank you. Yeah, so we look at some aspects of congenital adrenal hyperplasia. I'm informed that in the audience we have endocrinologists, we have general practitioners, and we also have non-medic personnel. So we'll make it simple, just to understand the basics of congenital adrenal hyperplasia, to allow us to pick the cases that may come across in our practice. So we look at the definition. We will look briefly at the adrenal gland anatomy and physiology. We look at the clinical presentation, investigations we can do, and treatment and the complications. After that, we'll briefly look at the challenges our patients face in Kenya before we switch to Uganda. So by definition, congenital adrenal hyperplasia is a group of diseases, so it's not one disease. And all of them arise from the inability to synthesize cortisol and excess production of either androgens or mineralocorticoids or both. They are autosomal recessive, including several genes that affect different enzymes, the commonest being 21 hydroxylase deficiency, which constitutes 95% of the cases, and 11 beta hydroxylase, which constitutes the remaining 5 to 10%. The others are rare. So if you look at the adrenal gland, it's a small gland on top of the kidneys. And when you slice it, it has a cortex and a medulla. And the cortex is divided into three. That is the three zones that you can see. Zona glomerulosa on the outside, fasciculata in the middle, and reticulata in the inside. This from these zones that we get the hormones. You see that the zona glomerulosa, that's the outer layer of the cortex, is the one that makes the mineralocorticoid, aldosterone. The middle zone, zona vasculata, makes the corticoid, cortisol. The zona reticularis, which is the inner zone of the cortex, makes the androgens. Then the medulla makes the catecholamines, adrenaline mainly. So this is the function of the adrenal gland, and these hormones, of course, are important in various processes in the body. Aldosterone maintains our blood pressure. Cortisol is a stress hormone, and the androgens, source of the sex steroids. And the way it functions is that the adrenal gland is controlled from the pituitary, and the pituitary is controlled from the hypothalamus. So you can see that we have this corticotropin releasing hormone that stimulates the pituitary gland to make ACTH. ACTH then stimulates the adrenal cortex to make cortisol, and that's among others. But cortisol is the only one that has feedback to the adrenal cortex, to the pituitary, and the hypothalamus. So the balance is that the more the cortisol, the less the ACTH. The less the cortisol, then the more the ACTH. And that's how the body balances the amount of cortisol that is available. So that when we look at this pathway, then you notice that this pathway is what happens in the adrenal cortex. And from cholesterol, then we make the hormones. So the mineralocorticoid, the glucocorticoid, and these are the androgens. So if cortisol is the only one that does the feedback mechanism, and you're not making cortisol, the ACTH will push all these pathways, and that's why you get excesses of either the mineralocorticoid or the androgens. So as you say, the commonest enzyme defect that we get in CAH is 21 alpha hydroxylase, and it blocks these two pathways, and therefore you don't get both the mineralocorticoid and the glucocorticoid. And in that you have excess of these precursors, which are then used to make the androgens. So you'll find that in 21 alpha hydroxylase, you'll not make enough cortisol and mineralocorticoid, but you'll have excess of the androstenedione, which is the precursor for the androgens. The other enzymes that are shown here, if you have the next commonest, which is 11 beta, you'll find that in this you'll have diminished cortisol secretion, but you have deoxycortisol and you have the other enzymes being in excess. And these patients will have, because of that, the phosphoandrogen fertilization and hypertension. If you have the very rare one, 3 beta, which will block the system and these stages, then you'll find that what you have is excess DHEA, which will virilize females, but because we lack the other androgens, the males will not also be fully virilized. So this could cause ambiguous genitalia for both genders. So this is a system that works in the adrenal cortex with the secretion of those hormones. And those are the enzymes and the pathways which are affected with certain products. How common is CAH? In Europe, it's about 15 by 100,000 newborns. In Israeli, the Ashkenazi Jews have the highest prevalence in the world. If you look at the prevalence of up to 1 in 30. India, from newborn screening, they have 1 in about 6,000. In China, they have about 400,000. Do you have anything in Kenya? We don't know how many patients we have in Kenya. What we've seen from 2 studies done at KNH which is our national referral hospital. And you have, of those patients who are investigated for DSDs, we had about 11% being CAH. And for those patients who have adrenal insufficiency, we had about 50%. But we are planning to conduct a study that will help us know exactly how many patients we have in Kenya and their presentation. How do patients with CAH present? So they are grouped into three. We have the classic CAH, which has two, either salt wasting or simple virulency. The most severe form of CAH is the salt wasting CAH. And this one is arises because other than the cortisol that is not made, you also don't make the mineralocorticoid. So they present with loss of electrolytes. They have vomiting and dehydration, usually in the second or third week of life. And they easily go into shock, and they may result in death if action is not done. Now, patients presenting like this, if the diagnosis is not picked at that stage, then you actually lose these patients. And our fear is that this could be happening to many of our patients who present. There are many, many neonates who come to us in shock. They come in electrolyte imbalances. And if you don't pick that as CAH, they end up dying. And that's the importance of discussing this topic, that if we can make this diagnosis and save our children, we would probably be having more surviving and more treatments. So those patients who come in vomiting, dehydrated, and shocked, especially the newborn period, think about CAH as one of the probable diagnoses. Then we have the simple virilizing CAH. Simple virilizing CAH, as it is called, is just that the females get virilized. So they grow, the rapid growth, the bone age is advanced. Males will also go into early puberty. Eventually, they are short. That's the final height, so they'll be short. The female has hirsutism, acne, that's usually in adulthood, and clitoromegaly. So these patients tend to present later in life. We don't see them that early. And you'll find that for boys, it's usually the early puberty. For the females, the hirsutism, clitoromegaly, and the acne could be presenting. In areas where the height is monitored closely, then you'll find that they have a space of rapid growth, but usually that ends up with early puberty and eventual short staging. Then we have the mildest form, the non-classic, non-classic CAH. This one will usually present much later in females with oligomenorrhea and infertility, a bit of fertilization. The males may be asymptomatic. This is the mildest form, which is also thought to be the commonest, but not diagnosed. It doesn't cause harm. The other common presentation for CAH is virilization, especially for females. Very rare forms, that is the 3-beta HSD, may present under virilized males, but most of them ambiguous genitalia. If it is CAH, it will be in females. So any patient who comes with the ambiguous genitalia and you cannot palpate any gonad, most likely that will be CAH. Why do they present with ambiguous genitalia? This diagram we are seeing here, the diagram of the development of the external genitalia. And as you can see from the differentiated genitalia, they look both male and female, look the same. And with the effect of the male hormones, then you'll find that the genital fold closes, and that forms the shaft of the penis. The scrotal swellings, which actually are also the same as the labia, they fuse in between to form the scrotum. And for females, that genital fold is not closed, and the labia folds become the labia majora, and you have the pituitary. So that's why if you are female and you expose them to male steroids, the male sex hormones, then they will not form the normal female, and they'll come somewhere in between female and female. And for the males, if you don't have enough hormone, then they look like females. That's how those. So they result in a patient like this, you can't tell whether they're male, female. This is what we call ambiguous genitalia. So when you see this kind of presentation in inpatient, then one of the things you will think of is congenital adrenal hyperplasia, and you must investigate such. So what investigations would you do? If they come with ambiguous genitalia, the emergency there is if you have salt wasting CAH. So you need to urgently establish whether they're making enough cortisol. You need to look at the urea electrolytes, although this usually goes up normal after 24 hours. You may want to do an pelvic ultrasound to see whether there are any uterus in the abdomen, in the pelvis, those are the Mullerian structures. You would want to do a karyotype to tell whether this patient is XX or XY. And 17-hydroxyprogesterone is what will give us a diagnosis of CAH. Now, in our country, in Kenya, this 17-hydroxyprogesterone will take time to, most labs will give you a turnaround time of between 1 and 2 weeks. But if you establish that the cortisol is low and you have electrolyte imbalances, especially hyponatremia, low sodium, and high potassium, hyperkalemia, with a patient with low cortisol, then you can treat CAH as you wait for the results of your 17-hydroxyprogesterone. Any newborn who come in sick, vomiting, and in shock must be investigated for CAH. Among the other things you do, we know that what we call gastroenteritis is common in our region, but in the newborn period, rule out CAH. And investigations will be cortisol, the electrolytes, and 17-hydroxyprogesterone if indicated. For the other less common causes of CAH, 11-beta and the other rare forms, then you may need to do an ACTH stimulation. Then you assess the products of the schema that we saw, the products of the adrenal cortex, the pre-products, all this, you look at those once you do an ACTH stimulation. In places where you have this tandem mass spectrometry, then it's usually one test, urine, test stimulation, and that will give you your answer. For a region, you may have to do the tests one at a time. Where available, you can do genetic testing to identify the gene. But usually this is not necessary for diagnosis and treatment. And what is this treatment? Treatment. We do medical treatment, and this is hydrocortisone. So we give hydrocortisone tablets. The dose is usually 10 to 15 milligrams per meter square body surface area. And you will need to adjust this for sick days, for surgery, serious trauma. For surgery, if you're doing major surgery, you triple the dose. And you start the evening before surgery and continue until a day or two after the procedure. For a patient who is severely sick, again, temperature setting 39, triple the dose until a day after the period of severe illness. For trauma, again, you triple the dose until you're out of the severe trauma. Now, if the patient is not very sick, your temperatures of 38, about to feed, then double the dose might do. Currently, we are seeing modified release hydrocortisone, usually for 12 years and older. This one has hydrocortisone slow release, so it's given twice. The usual hydrocortisone tablets we get, we need to give them 3 times. The half-life of hydrocortisone is 8 hours. So to cover the 24 hours, you need to give it 3 times. Usually, you give half the dose in the morning, quarter of the dose in the afternoon, quarter at night. That should be able to cover 24 hours. And we give half the dose in the morning, because that's the normal time when we have the diurnal variation of cortisol in our system. It is highest in the morning. So we try and mimic that by giving a higher dose in the morning. Children with salt wasting CAH require fluid cortisone. This is a mineralocorticoid that helps to retain sodium, and you give another dose. Some may require salt supplementation. So these two usually required in the newborn period, at least they go beyond 1 year. Then they are more sensitive to cortisone, and you may not need to give cortisone salt. If a patient requires very high cortisone doses, then an introduction of cortisone and salt supplementation may actually enable you to use less of the hydrocortisone with well control. And as you treat these patients, you will use 17-hydroxyprogesterone levels and androstenedione, that is to monitor the control of 21-alpha-hydroxylase CAH. You will also monitor the growth and the bone age. If you give too much of the treatments, you may have low 17-hydroxyprogesterone, but you'll have poor growth. So you need to monitor growth, look at the bone age as you look at the enzyme, the products of the enzymatic abnormalities. Surgical treatment. Surgical treatment, usually the timing of surgery is not clearly defined. Most authorities would say the first 1 year of life. But some of the patients, you make a diagnosis much later in life, may require surgery then. Usually the earliest surgery may be done is vaginoplasty. For those who have clitoromegaly, is clitoroplasty. For those who have clitoromegaly, that's reduced. But later for sexual function, they may require vaginoplasties. For males who have undescended testes, autopexy, and hypospadias. Okay? The controversial one is bilateral adrenalectomy for patients who are very difficult to control and having a lot of these male androgens. The androgens, and you're difficult to control your treatment. Some time ago, bilateral adrenalectomy used to be done. Then you continue with the hydrocortisone. But this is controversial because there are other functions of the adrenal glands that you will interfere with when you do. So for those who require surgery, control the surgeons, the earlier the better. So in terms of clitoroplasty, scarring, but vaginoplasties are usually done later for sexual function. On follow-up, then you monitor growth, as we said. And as we say, if you don't treat them, then they go into early puberty, advanced bone age, they close early, they become short. If you give too much steroid, then the steroid also will affect growth and will be short. So you monitor growth as a balance of your treatment. If there are adequate treatment, then growth should not be impaired. And that means you make the diagnosis early and give adequate treatment. Puberty. Most of the children with CAH, 21 hydroxylase and 11, will go into early puberty. The chronic stimulation from the androgens will trigger them into early puberty, and that may require attention. The rare forms, like 3-beta, may delay in puberty, and you may need to, especially for the males. Hypertension, yes. If we are not getting enough cortisol and we have excess of mineralocorticoid, we get hypertension. If you give too much steroid doses treatment, you can also get hypertension. So you monitor for blood pressure and control treatment appropriately to have a normal pressure. These are unique patients, but use of hydrocortisone can actually treat the hypertension in these patients. Psychological issues, especially on the gender role. The girls who have ambiguous genitalia, the boys who have ambiguous genitalia may have psychological issues. Some patients with CAH and females who are not treated and you pick them late in life, you may find that what you will be having is Clitoris might be as big as a penis, and oftentimes some of them would be raised as males. So gender issues, gender role, and psychological issues around the gender role must be dealt with. Adrenal crisis, in terms of stress, trauma, illness, they may go into adrenal crisis, which you need to identify. So it's, as you said, those who come in vomiting and shock, that's one of the adrenal crisis. And this may happen anytime in their lives. If they are so sick that they cannot take oral hydrocortisone, then IV hydrocortisone can be given, or dexamethasone or methylprednisolone. Those, all of them will save life. Then when they're able to take orally, you switch to hydrocortisone. Hydrocortisone is used in treatment because of it's the one that affects the growth list. The side effects of hydrocortisone are better than prednisolone and dexamethasone. Obesity, again, may arise from the steroids we're using to treat. The adrenal androgen stimulation of the gonads may result in the adrenal gonad or adrenal rest tumors, usually in the either ovaries or testis more commonly, but in adrenal. This is because of the overstimulation. They may have cataracts from steroids and infertility. Now, infertility occurs in both genders in patients with CAH. For the males, the infertility arises from inability to have a normal sperm count. For females, usually it's the interference with the natural hormonal profile from the androgens. And usually they would have oligomenorrhea, some may have amenorrhea. And it's only when you treat them appropriately that they get fertile. And if one is fertile and they intend to get pregnant or they're pregnant, then control must be very good to allow them to carry pregnancy. What's happening in Kenya? So in Kenya, we don't know the exact number of patients. We don't have a neonatal screening program, and this is what is used in many countries to talk of the incidence of CAH. The pediatric endocrinology specialists are found around Nairobi and the neighboring counties, and these are so few for the country. So we actually don't know what's happening on the patients. We don't know what's happening on patients that are found elsewhere in the country. And that's the need that we've gotten some funds from plan, and we intend to go around the country and see what's happening among our patients. Availability of hydrocortisone. This has been erratic and sometimes been very expensive. A few of our patients are getting them from online outlets. And this has made it a little bit better in terms of sourcing for the hydrocortisone. We would really like that this hydrocortisone, I know hydrocortisone injectable is available quite in most of our country facilities. But the tablets, we would like it to be the essential drugs list so that all, at least our county referral hospital should have and avail it for the patients that are diagnosed in these areas. Do we do surgical interventions in Kenya? Yes. Our patients are diagnosed late, and they somehow, I think, I don't know if it's from our training or where we get the habit that if we see a patient with ambiguous genitalia, we send them to the surgeons, and the surgeons will try and correct. Although this is getting rarer and rarer now, as most of these surgeons will refer the patients for investigations first, make a diagnosis before they do any surgical interventions. Thank you. Back to you, Suzuki. Suzuki, are you with us?
Hello. Sorry for that. Can you hear me now?
Yes, I can hear you. Back to
Yes. Thank you, Dr. for your insightful and expertise, your knowledge, and for the information you've given us today. The questions I think I will answer after Dr. Esther Cobell has done a presentation, because there are also questions concerning the session you just presented. So if that's okay, we'll go to Dr. Esther Cobell. Dr. Esther? Hello?
Yes, hello, Riziki. Can you hear me?
Yes, we can hear you.
Hello?
You can press, hello, can you hear? Yes, we can hear you. Can you hear me? Hello? Okay, as Dr. Esther tries to connect in, we can proceed with the questions for Dr.
Yes, Riziki. Hello?
Oh, she's back, sorry.
Request Riziki to help me share my slides.
Okay.
Recording in progress.
Thank you.
A minute.
Okay, thank you. My name is Dr. Esther Cobell. I am a pediatrician from Uganda, and I work with CLAN, Child Health Africa. It's one of the partners of CLAN, the international, the Australian-based organization. I'm going to share the unmet needs of children with CAH in Uganda. So just to briefly talk about CLAN Child Health Africa, we are an NGO. We work with parents who have children with chronic illnesses and state of life for children living with chronic health conditions in Uganda. We have specifically worked in 4 communities so far. So that is epilepsy, sickle cell disease, congenital adrenal hyperplasia, and then cerebral palsy. And we really try to work with these communities through 5 main pillars of care, and with really family support groups as the main visual hub for our reaching out to these communities. So using these 5 pillars of care, we're able to reach individuals, we're able to reach families, we're able to reach the government officials, policymakers, really everyone else that is involved in taking care of our children. And these pillars include ensuring affordable access to medication and equipment, seeing that every child is able to afford to get medicine, able to be diagnosed for the diseases that they have, and they have a true diagnosis. The second pillar is to do with education, research, and advocacy. So here we literally work with educating the community, educating the parents and their children about their disease, the specific based care for these children, and also advocate for improvement in their care. Our third pillar is optical medical management, and this really focuses on seeing that every child is able to have access to care. So it is the children are taken care of with their chronic health illnesses. Our fourth pillar is to encourage family support groups for these different conditions. We know that chronic health conditions tend to have a lot of impact on family, and it comes with a lot of stress on these parents and the children as well. But if they can work together, if they can connect with other parents and children who are living with a similar condition like them, then it will be easier for them to deal with their disease, because then they learn from others who are going through what they're going through. So we support a lot formation of family support groups, and this is something that we have so far really done with the epilepsy community. We have a family support group that we are working with. The fifth pillar is to reduce poverty and promote financial independence. So even down to the family support groups that these parents have formed, we see that we support them to be able to create their own livelihoods, to take care of their children, and without worrying about the burden. So they should be able to always have money to buy medicine and to take their children to the health facilities to get treatment. So that is really what we focus on in Clan Child Health Africa. So today I'm going to talk about the challenges for the CAH community. What does it look like in Uganda? So globally, about 1 in 1,600 children are affected by CAH. But when it comes down to Uganda per se, we do not have data on the prevalence of CAH. We don't know how the disease is like in our situation. And I can see our colleagues from Kenya are experiencing a similar situation. So additional to not having sufficient data on the prevalence of the disease in Uganda, the knowledge about awareness about the disease itself is also very limited. And it's not only among the health workers, so it's among health workers, among the community, in the government. It's difficult for us to walk to the Ministry of Health and request them to include one of the drugs for children with congenital adrenal hyperplasia on the essential medical list, because they do not know about the disease. So that is some of the challenges that are existing regarding awareness about about CAH. It's sad to say that many of our health workers do not know about CAH. The pediatricians, yes, get to learn more about it during their study, postgraduate study. But when we look at the rest of our primary health caregivers, the obstetricians who deliver these children and receive them, they don't know much about the disease. When we look at the nurses, the midwives at the lower health facilities, they do not know about the disease, so they really miss out a lot on these issues. In one of our health facilities here, the National Referral, there are only 10 children who have a confirmed diagnosis of CAH and are receiving treatment for CAH. However, there are many more children in the clinic. They attend care, they have ambiguous genitalia, but they've never really been diagnosed for CAH. The diagnosis has never really been done in these children. And when I look at access to medical care here, I'm happy our colleagues in Kenya have 6, if I saw right, 6 endocrinologists. In Uganda, they are only 3. And yet we see that our population, almost more than 50% of the population is under 15 years. And yet we have very few super specialists to take care of these children. We have 3 pediatric endocrinologists. 2 of them are really based within the central, within the capital city, and 1 is located in the northern region. So what is happening to the children who have CAH in the eastern, southern regions of the country, we do not know. And this of course, really delays access to care for these children. The other, I've already alluded to it, the lack of knowledge among health workers. So many of them do not know how children with CIH present. They do not know what tests they should do. Sometimes some of them don't even know who to refer the child to. There are those who don't even know that we have endocrinologists in our country, and that is very unfortunate. I had a conversation with one of our endocrinologists, and she was sharing this. So this is what she said. She received a child who had been born at one of the national referral hospitals, and this child had been sent home. But when the mother gets home, she realizes my child's genitals do not look that. She was told it's a girl, but when she looked at them, it was not clearly a girl. So she was concerned and went back to the hospital. But this is a mother who delivered in a hospital, was seen by a midwife and told, you have delivered a baby girl, and she went home. So that is some of the things that we are seeing existing in our community here in Uganda, and it's very, very unfortunate. When we look at the issues to do with access to diagnostics and medicines, of course, if the health workers do not know about the disease, then that means they also really don't know how much they can investigate for this disease. Even for children who are presenting with a neonate who is vomiting, who has severe dehydration, some of the health workers do not know that in such a child, I need to look further than doing serum electrolytes for this child and looking for infection as the reason why this child is presenting this way. So there's that knowledge gap that exists in regards to tests to be done. But we also see that the tests are really expensive. Well, I know that we may think doing serum electrolytes is affordable, ultrasound is affordable, and X-ray is affordable, but for our parents here that we see, most of them do not really earn so well. So when you put a package of all these tests together, they cannot actually afford even the bare minimum to do an ultrasound scan for their child. 17 is why we see that we have children in our clinic who have ambiguous genitalia but have not been investigated for CAH because their parents cannot afford to pay for these tests. And we also see the tests like karyotyping, for example. Samples are sent to South Africa. Results will come back maybe after 5 days. But it's around 500,000 shillings, Uganda shillings, and that is really not affordable for very many of our parents. So that has really contributed a lot to delays in and diagnosis for these children. So they end up developing complications later in their lives. When we look at access to medicine, still the issues are the same. Drugs, this hydrocortisone is not a drug that is covered on insurance. So that means most patients parents have to pay out of pocket for this medicine. It's expensive for them to keep buying. They run out of stock. And so that means these children are at risk of ending up coming back often in adrenal crisis because they are not getting their medicine as they are supposed to get. So that is very, very unfortunate, and we are trying to see how we can support the parents to be able to have this medication for their children. So this is the last thing that I'm going to talk about: social support and community perceptions. So there are only 10 parents with children with CAH, but all these parents do not, they have nothing that brings them together. They have no common link. And this means that they have to deal with this disease alone, on their own, individually. And of course, this impacts a lot on their mental health, their mental well-being, and how they interact with their families back at home. We also know that CAH commonly presents with ambiguous genitalia, which is a social emergency. And of course, most parents, the first thing they'll think to do is unfortunately, they may decide to hide the child's situation. So they may pretend and decide to hide that this is maybe they decide to raise it as the child as a girl when it's actually a boy, and raise as a boy when it's actually a girl. So all those things can happen. And even the community itself is a lot biased about these children who have genital ambiguity, because first of all, they don't understand how it comes about, but also we have our traditional beliefs, African society, where people believe maybe someone is bewitched, and this makes it difficult for such children to fit in the community, and it makes it difficult for them to fit in, and also impacts on how they lead their lives, really. So I just wanted to share with you what we have seen in the CAH community, and for what we are doing to be able to address some of these challenges in this community is we recently won a grant from Mates for Kids, and it's going to support us to do healthcare capacity strengthening. So we are selecting one of our national referral hospitals, and this may be like a bit of a pilot. So we want to work with the health workers, right down to the nurses, the midwives, the medical officers. Then we also want to work with the obstetricians and gynecologists. We see that we educate them about congenital adrenal hyperplasia. So we are focusing on really visual screening. So what do you look out for to at least pick a high risk child or with congenital adrenal hyperplasia? So any neonate who is presenting with vomitings are things that we want to emphasize to the health workers, that these children, you should look beyond the basic tests that we usually do, and do additional tests for them, but also, if not possible, at least see that this child is referred to a pediatric endocrinologist for further follow-up. So that is something that we are working on right now. And also we are going to form the family support group for these parents who have children with epilepsy, with children with congenital adrenal hyperplasia who we know are confirmed. And then we work with them to also make sure that they have their medicines provided for them. So thank you very much for listening in. I welcome any questions or clarifications. Thank you.
Thank you so much, Dr. Cobell, for your insightful and engaging webinar. We have learned a lot. There are questions here, but I'm seeing most of them have been answered. Starting from Dr. Polaigang. I don't know whether to go through them. And then there are those that are directed to you. So for Dr. Lycon, should I go through again the question and answer, the answered ones, or kindly advise?
So I don't know whether someone needs any further clarification after the answers are given.
Because I'm seeing you've answered actually all of the questions, and I think it's others might want to know exactly what was asked and the questions that were and the answers that were given.
Okay, so, then we continue with the questions. I'll answer them.
Okay. We have one is saying excellent presentation, Dr. Let me go to the questions. Please clarify on how CAH affects males.
Okay, so CAH in terms of is autosomal recessive, so it's not more prevalent in males than females. It affects both gender equally. The diagnosis usually early in life, is more for females because of the ambiguous genitalia, and the males may not have ambiguous genitalia. But in terms of the electrolyte imbalances, in terms of the vomiting and shock, it affects both gender equally. So when you think of salt wasting CAH, it will affect both. Now, you may miss a diagnosis in males because they will come in vomiting and shock, but you don't see the ambiguous genitalia. So you may not think quickly that this could be CAH, while in girls, because there'll be ambiguity in the genitalia. Now, the only one is the non-classic CAH. Non-classic CAH is for males, sometimes it's asymptomatic and may not require treatment, or they may just go into precocious puberty and that will be sorted out. While in the females, of course, the virilization will cause many other symptoms. So that's how it affects males.
Okay, thank you for your answer. And then there is another question. What is the likelihood of using a pump for CAH patients?
So using a pump to provide or to give a dose of hydrocortisone, I think has been tried in some parts of this world. And just like the insulin pump, so that it controls the dose, you adjust that it gives a higher dose in the morning, in the afternoon less, at night gives the list of the dose. This is not available as a regular mode of treatment. And for our country, and I guess most of Africa, we still rely on the tablets. But yes, it's an option for those who are able to.
Okay, thank you. Another question. We are 15 pediatric endocrinologists in Kenya, but largely in the city or just around the city.
Yes, I think Dr. Esther thought we are only 6, but we're actually 15.
Okay.
And I think in Uganda, we have a 4th one who may be not actively practicing in the eastern part of Uganda. Thank you.
You're welcome. This one is for you, Dr. Esther. I think that will, thank you, Rose. I think that's for you, Dr. Esther. We're experiencing the same situation of misdiagnosis, paucity of data in Zimbabwe. We run a clinic for DSD, ambiguous genitalia at the Central Hospital. My thinking is that while working with CAH patients, we also include DSD communities as a whole. The challenges they face are similar, and this will increase the advocacy that needs to be done for these families. For those ones who want the notes, they can follow the KNH website. We'll share the slides. We have kindly shed more light about diet management for babies with CAH. I have taken care of one who kept getting hypoglycemia despite going up on dextrose concentration.
Yes, the lack of cortisol is usually what causes hypoglycemia in these patients. And even as you give dextrose, the insulin, the action of insulin is not opposed by the cortisol. And that's why they get hypoglycemia. So the best treatment for this would be to give hydrocortisone. Probably you need a slightly higher dose, and that would control the hypoglycemia.
Okay. Okay, another question. I know of an adult with chronic HX or vomiting. No cause of identified yet. Could it be CAH?
An adult with vomiting?
Yes. An adult with chronic HX of vomiting.
Yes, history of vomiting. So the history of vomiting in adults is more of gastrointestinal system issues. So I think you'll be sending them to a gastroenterologist first. But if you do the electrolytes and they are normal, probably it is not CAH. There are other things in the GIT that can cause vomiting, especially in adults. that may need a gastroenterologist review. Thank you.
Thank you. There's one who's asking for Dr. Esther. The presenter insisted on hydrocortisone. Therefore, in the event that there is hydrocortisone, can the provost or trimsinolone be given? Sorry, let me ask this again. The first presenter, that is you, Dr. Paul, insisted on hydrocortisone. Therefore, in the event that there is hydrocortisone, can diprofen or prednisolone be given?
Yeah, so generally any steroid can be used. The difference is in these steroids the side effect profiles, and especially the effect on growth, the effect on hypertension, and weight. And you'll find that why we are giving this is because of the glucocorticoid effect, and the one that gives us least side effects, and the one that is short acting is hydrocortisone, and that's why it is used. The half-life is 8 hours. You give a higher dose in the morning, afternoon another dose, and evening another dose. If you're to use things like ibuprofen, this is something that works for a long time, and you cannot change it to make it higher in the day, the morning, and less in the evening. And that's a problem that dexamethasone and prednisolone, which are more common than triamcinolone and ibuprofen in our area, that's the same effect they have. And that's why we don't use them. We use hydrocortisone. So I insist that we use hydrocortisone. If that is not available, the next best would be prednisolone. And once you go beyond that to dexamethasone and these other steroids, then your side effect profile become worse, and the patient may not get the optimum growth and quality of life.
Okay.
So hydrocortisone is the best choice. Thank you.
Thank you. Is the treatment lifelong, or does the condition improve with time?
The treatment is lifelong.
It's
The
a
treatment
lifelong.
Yeah, so when you start early in neonatal period, you may need fludrocortisone and salt supplementation. As they go beyond 1 year, hydrocortisone alone could be enough, and treatment is lifelong. Thank you.
What are the? I think I can ask 3 more. What are the prospects of viable adrenal tissue transplant?
Adrenal transplants.
Yeah, the question is, what are the prospects of viable adrenal tissue transplant?
I think in theory that is viable, but in practice is that any person who gets a transplant will require anti-rejection medication, and the side effects profiles of those are worse than hydrocortisone. So I don't think that would be an option as it is currently, unless we have a way of transplanting without requiring the anti-rejection medication.
Thank you, Dr. I think I saw a question for Dr. Esther. Let me see. About clan. But before I get to it, there's appreciation for Marika. She said, they're saying, thank you for excellent presentation, Dr. Laigong and Dr. Kobel. Thank you for the insight to the situation of children and adults with CAH and to the situation of families. I am a representative of the CAH International, a worldwide network of CAH groups, which started 2 years ago. It is very important for us to get to know about the needs of people with CAH. So thank you. That I will be with you tonight. Thank you for the organization. Excellent moderation. That's appreciation. For the rest who are asking for the slides, we'll share with the KNH website. I think, do we still have time for more questions, Dr. 'Cause I think we have exhausted.
Yeah,
Thank you, everyone. I think that's a wrap. Let me say, on behalf of Magic Foundation Africa, I would like to extend my heartfelt gratitude to Dr. Paula Egol, Dr. Esther Cobell, for sharing their expertise, knowledge, and valuable insight with us. And for the rest, thank you for joining us today for this insightful and engaging webinar. I want to wish everyone a lovely evening.
thank you and have a good evening, everyone. Bye.
Thank you and have a good evening.
Thank you, Dr. Esther.